opportunity to talk about knee injuries. And my first case is briefly discuss with you ACL injuries in children and in adolescents. So I will discuss briefly a case that we saw some years ago. He arrives in the clinic. He had a non-contact knee injury during a soccer game. 14 years old, ACL rupture. He had a pivot Lachman grade 3. No improvement at this young age with physiotherapy that we will discuss slightly later. And he had his ACL reconstruction done with hamstrings, fixation, classical fixation with suspension, fixation in the femur, and interference screw in the tibia. Here you see his X-ray. You see that the growth plate is still open. On the upper right, or upper left, you see the classical signs, the bone edema in the femur and the tibia when they have this pivot trauma. You have the AP view in the MRI, and you also see on the lateral view that you see that he has a complete ACL injuries. So in children, when we see children or adolescent coming to your clinic with swelling and hemarthrosis, we know from several studies that it's either a ligament injury, either a patella dislocation, or a major meniscal tear in the red zone. And we also know that in children below 12 years, we have mostly bony avulsions where we have these ACL injuries. However, above 12 years, 9 out of 10 of the patients having a pivot trauma, they have a ligament injury. This is, however, rare in younger patients, and they are mainly sport injuries, these ligament injuries in children and adolescents. You see that of all ACL injuries, it's only 5%, but however, 5% is important in this young patient group. And there is 1 out of 100,000 children every year having an ACL injury. This has been mentioned by the previous authors as well. It's always important to examine both knees, especially in these young children. And we know that there is, in younger age, in children, there is a physiological anterior knee laxity, and this is decreasing over age. You see it and in female and in male patients. So over the age of 13 years, it starts really to decrease. But if you have very young children with suspicious ACL injuries, there is often an ACL laxity, and we should be very cautious, and we should definitely diagnose the correct ACL derangement. We also know that the MRI in children, the sensitivity and specificity in children below 12 to 10 years, it's quite low. So we should be suspicious if we think that the MRI shows an MRI tear. In adolescents, the sensitivity and specificity is slightly higher, so more trustable, but be always aware about false positivity in this young Asian group. The meniscus, we should always examine the meniscus. In this young patient, he had no clinical signs of meniscal tear, and that was neither shown on the MRI. But primary meniscal tears is quite often in acute injuries, 3 out of 10 to everybody, but secondary, this is very important. Secondary meniscal tears, and mainly in the medial meniscus, will happen almost in every patient in the first year if the ACL rupture is not corrected. Which surgical technique can we use? We have the epiphyseal, extraphyseal, and I think when the growth plate is almost closed, as it is in this case that's presented here, we can go transphyseal without any major risk of growth disturbance. What about the tibial tunnel? It should be central to avoid any growth problems. It's very important. The femoral tunnel is eccentric, is posterolateral, but we also know that any growth changes, they are rare if we have somebody experienced in ACL surgeries. Few cases are presented in the literature. The biggest study has been done by the French Society, who followed all the ACL injuries in children over a period of time, and they presented few cases in the literature. If they occur, the growth changes, they will progress until the end of growth, but the vast majority, they are caused by technical injuries during the initial ACL surgery. So in summary, for ACL injuries in children and in adolescents, they are not too rare. We should always be cautious, but the diagnosis is often delayed because sometimes we don't think about it. We have some anterior laxity in the young children and we are not really focusing on the ACL. Be aware, and this is so important in young patients, the secondary meniscal tears in the upcoming year if the knee is not stabilized, and even cartilage lesions are present in the first year. ACL reconstruction in this young patient group, they have good clinical result, so we should not be reluctant to perform a stabilization of the knee. Growth changes, they are rare if the tunnel is central and we are not damaging too much the growth plates, but be aware of technical problems that can happen, and this is the major cause of growth changes in this young patient group. And follow the patients if you are suspicious to any growth disturbances. Follow the patient over a long time, over several years until the growth is ended. That's also important to see if you have provoked any growth abnormalities. So this is what I would like to discuss with you, the ACL injuries in children and adolescents. This young patient, he only had the hamstring reconstruction. He has he's now 3 years out after he's now 17 years, stable knee, and he's doing sports at normal level again. Thank you so much.